Hello everyone and welcome back to Waveform Capnography. My name is Kate Marquis, I'm a nurse here at Life Support Learning Center, and we're going to talk to you today about alterations in waveforms. So this is talking about a little bit more advanced stuff than what we did with part one being the building blocks, and now we're going to talk about kind of weird things starting to happen here. So our objectives throughout the entire series here is to define capnography, which we did in our last lecture, to identify our three uses for capnography, and to correlate changes in patient condition with changes in our capnography readings. So we're going to hit those last two here today. So again, our normal end-tidal CO2 is between 35 and 45, but keeping in mind that if our patient is outside that range, I have to sit there and think about why. Is that something that's expected? Like in my pregnant patients, whose end-tidal CO2 may be between 26 to 34 because of normal kind of hyperventilation there? Or is it just wonky because it's wonky and now I need to go check on my patients? Our warning readings, again, are below 20 or above 50 as they are associated with poor outcomes. So this is our normal waveform. We're going to talk about abnormal waveforms. We need to start with what normal looks like, right? Again, we're seeing phase one, our respiratory baseline. That is during inspiration. My end-tidal CO2 should be reading 0. At phase 2 here, we have that expiratory upstroke. That's where our expiration begins. We're getting past all the alveolar dead space there. Moving on to phase 3, we hit that alveolar plateau. We should have uniform PaCO2 throughout. And again, we're noting that it's slightly rising here up until we get to that upper right-hand corner, which is just before inspiration begins again, which is where we're measuring our end-tidal CO2. Notice that phase 4 or phase 0 is again that inspiratory downstroke. So is there a problem? Now we got to remember that end-tidal CO2 is a tool that we can utilize here, and the tool is only as good as the person who's using it. So waveform capnography must be utilized in conjunction with our clinical judgment here. You see something weird, check your patient. Am I expecting this kind of weird number, weird waveform, based on my patient's clinical presentation? Is there a reason the numbers are too high or too low? Did I do that? Was I responsible for the numbers going higher or lower than they have been? Or has my patient deteriorated? Go check on your patient. Also, check your device. Ensure that the device is placed properly on the patient. Ensure that the waveform is a good waveform. And ensure that the system is functioning properly. Right? There's a dope mnemonic for a reason, and E, equipment failure, is on it specifically for that. Again, thinking about our normal waveform, this is what a normal waveform looks like before we sashay here into asthma or COPD, which will give me an abnormal waveform. This is an obstructive disease, and what I'm seeing here is this shark fin waveform. Kind of reminds me of Finding Nemo there. I have an extended phase 3, which is my expiratory phase, right? I don't have that cool plateau guy that's kind of rising a little bit. I don't have my boxy rectangular shaped waveform, and this is due to the obstruction or bronchospasm that's occurring here. My patient has a prolonged expiratory phase, and you can see that in your asthma patients. If you've never seen it before, check it out. Watch them. Their expiratory phase is really long, and it's because they're breathing through that obstruction or that bronchospasm there. All right, so this is going to have a delay in our alveolar emptying, which is why we have this weird kind of waveform. Keep in mind, you may see an initial fall in end-tidal CO2 followed by a rapid rise as your patient begins to decompensate. I don't like really high end-tidal CO2s. I could be seeing my patient moving into respiratory failure. That's kind of what that signifies. So these are kind of things that we want to keep in the back of our head. Moving on to our intubated patients here. I work in the ED, and typically speaking, what my physician will use first is a colorimetric CO2 device once they intubate someone. Now that's really great. It gives you a pretty quick reading, right? Purple is poor, Barney is bad, yellow is yes. I know whether or not I'm in the right place, but it's a glorified piece of litmus paper. It's only good for one use. So one and done. Okay, I see where it is. now I have no way of trending whether or not my tube moved or my patient is now right main stemmed or something weird has happened. I can't detect issues with ventilation before the onset of hypoxia without it. So let's utilize our waveform capnography here because I can use all of these things. I have a waveform and I have numeric changes. If my tube becomes dislodged, I can see on the screen my tube becoming dislodged based on the waveform. I can see if my patient becomes right main stemmed based on the waveform, or if I have a cuff leak based on the waveform, and we'll look at all those waveforms in a minute. In fact, if I even use end-tidal CO2 in my capnography before we intubate my patient, it can help my physician detect paralysis of my patient faster than the physician's judgment. It'll detect issues with my ventilation before the onset of hypoxia as we continue on monitoring our patient here. And it's going to aid us in the prediction of respiratory failure. So if I can go in and I can intervene faster than I normally would have, why would I not utilize this device? It's a fantastic device to use. All right, so utilizing the tools that we have available to us. So when we do have our endotracheal tube placed, there are a myriad of waveforms that we can see here. So we're looking at 4A, that's our upper left-hand corner. And I see a near flat line of apnea and moving into that rounded shape there. Now that's quite a long line of apnea there, so what I'm thinking is potentially the physician just intubated the patient, and that big movement to that normal rounded rectangle there is when we deliver that first breath to see whether or not we're in the right place. Moving on to 4B, what you're looking at is a biphasic waveform. So it kind of looks like, the top of a cliff, if you will. That biphasic waveform indicates a problem with our airway placement. Specifically, the patient is probably right main stemmed. So I do get numbers because I am, in fact, in the lungs. However, it's kind of almost like a cliff. It's kind of a cliffy kind of waveform there because I'm not getting the full exhale out, not all the CO2 out, really that consistent number, if you will. 4C is a near normal shape, indicating successful airway placement. That makes me happy. It brings me joy. It's what it's supposed to look like once we've placed our airway. I have my happy little boxy waveform with that slight increase on that alveolar plateau there. Being mindful that if my physician misplaced my ET tube, there's going to be no alveolar plateau at all. Finally, we're looking at 4D, which is a sudden drop. So this indicates one of two things to me. The tube has become displaced, as in my patient may have pulled my tube out, or maybe my equipment got pulled and it started yanking on the tube, or something bad has happened. Or the worst case scenario, and yes, there is a worst case scenario, is my patient is in cardiac arrest. So neither of those are ideal. So this is one of those waveforms that you see that you kind of bust into that patient's room to see what's going on if you're not already there. So go in, again, checking your patient. Two more things that you may see. The one on the left here is your Curare Cleft. So what's happening here is your patient is attempting to initiate a breath during mechanical ventilation. So they're vented, everything is wonderful, and you can actually see them try to take a breath there. Now, the depth of that cleft is dependent on the degree of muscle paralysis. So if my paralytic is starting to wear off, which eventually it will, and my patient tries to initiate a breath over the vent, you can actually see a deeper and deeper cleft there. It might be something that you want to go investigate additional sedation medication for. If you move on to the right side of the screen here, you're going to see an inadequate seal around our endotracheal tube. So what happened here? Why do I have this inadequate seal? Well, maybe I had equipment failure. So maybe my cuff burst or something like that, or it's leaking. That doesn't make me feel good, and I can actually see how my waveform has changed into kind of that more rounded waveform rather than that boxy kind of looking waveform that I'm looking for. Or maybe, you know, someone wanted to do a tube exchange and they started taking some air out of my tube, or out of the cuff rather, and they forgot to pull out the tube or take it completely out, or maybe they didn't fill it all the way. Right? So maybe they put an inadequate amount of air in the cuff. There are a myriad of things that could happen there, but you should really go check on that tube to make sure it's where it's supposed to be and it hasn't migrated elsewhere. Otherwise, you'll end up with a displacement as well. So in summary, a typical waveform is a rectangle. It's boxy in nature. Changes to this waveform can have a variety of etiologies, depending on the presenting shape and the underlying condition of the patient and what we have done to the patient. Changes may be an early sign of decompensation when utilized, but check your patient, okay? Again, waveform capnography is a tool that you can utilize to help you intervene faster and more efficiently. So check your patient, check your device. I want to thank you guys for joining me today. We have another presentation coming up talking about the applications of end-tidal CO2 to both the medical and the trauma patient. I hope you can join me. That presentation is located in the details below as well as on our website here. I hope you guys have a great day, and I hope to see you soon.